Hello, I'm Jorge Salluh from Rio de Janeiro, Brazil. I'm an intensivist and from the Door Institute for Research and Education. Thanks for the invitation for this session to talk about how to evaluate ICU efficiency with a focus on process of care and organization. This is my conflict of interest. And the main objectives in the next 12 minutes will be to look into why should we use process of care measures to evaluate ICU efficiency. Also, what's the evidence behind process of care measures as surrogates of intensive care efficiency. And finally, a little bit on how to measure process of care in practice. So first of all, we have to remember that we're still Donabedian in the sense that we still use the main domains of organization structure, process, and of course outcomes to evaluate the efficiency of our intensive care units. The traditional metrics to evaluate ICU efficiency, as you know, are mortality rates, both ICU and hospital mortality, preferably risk-adjusted mortality, lengths of stay, unplanned readmissions, and ICU-acquired complications, among a set of indicators of quality and efficiency. However, process of care has been used more and more. The reason to use process of care measures are simple. So the first one is that process of care measures can be considered proxies of adherence to evidence-based medicine measures on the bedside. That being said, they can be used to try to evaluate what's the adherence or what are the rates of adherence to process of care and protocols that are associated with best practices in intensive care. The second one is that unlike some of the classical indicators of efficiency, process of care measures are modifiable. Therefore, the data that you get from the rates of adherence, let's say, to a bundle of prevention of ICU-acquired infection or adherence to some protocol is actually actionable. That being said, it can be changed by changes in the process and changes in the interventions that are practiced in the intensive care unit. Also, there's current evidence of strong association of adherence to process of care measures and improved outcomes for ICU patients. Finally, there's the COVID-19 scenario. So right now, the usual indicators of efficiency, that being said, lengths of stay, readmissions, mortality rates, they are really messed up by the COVID-19 changes in the usual case mix of intensive care units. Therefore, we lost a little bit on the benchmark of what actually means to be efficient in this COVID-19 scenario. Therefore, using process of care measures can be also a surrogate for efficiency, even in a complicated scenario such as the current one that we lived into 2020. Finally, process of care measures, they follow the SMART approach, that being perspective of variables that are specific, measurable, they are acceptable, they are realistic, and they are time-bound. So this makes them good candidates to be used as proxies of ICU efficiency. What's the evidence behind it? Well, the first one that I want to mention is this study conducted by the Brazilian Intensive Care Network. It was published in JAMA 4 years ago. It was a cluster randomized trial that randomized 118 ICUs and almost 7,000 patients to a control group where there was no intervention at all, just a data assessment and collection, and an intervention group where a daily checklist coupled with daily goals were applied to all patients staying for more than 48 hours in the ICU. In this study, what we showed was that the use of checklists improved quality of care measures. That being said, the adherence to protective ventilation, to moderate to light sedation, and reduced the use of invasive devices in critical care, therefore guaranteeing the safety of these patients in intensive care. Also, this study from a Brazilian network of private hospitals, 10 hospitals in Sao Paulo, showed that actually when implemented, coupled a checklist plus sedation protocols managed by the multidisciplinary team with the involvement of the clinical pharmacist, were associated with reduction, substantial reduction actually, in the consumption of sedatives and also in the duration of mechanical ventilation of patients in this pre and post analysis. Finally, we also performed a large multi-center study called the Orchestra Study. This is the first article coming from it, already 5 years old right now, where we evaluated the impact of organizational practices in the outcomes of ICU patients. Almost 60,000 ICU admissions in 78 intensive care units in Brazil. And what we showed is that the more protocols you have implemented in your unit, that being said, protocols that are associated either with time-dependent diseases such as sepsis, cerebrovascular diseases, and cardiovascular diseases, or protocols that are associated with prevention of ICU-acquired complications such as DVT prophylaxis, VAP, and catheter-related infections, for example. The more protocols you had, the more efficient the ICU was. That being said, the less risk-adjusted lengths of stay was identified in the intensive care unit. But also, very interestingly, when you had a large number of protocols implemented in the unit and they were managed in a jointly way, and that being said, in a multidisciplinary way, it was also associated with reductions of hospital mortality for ICU patients. Also, we tried to look in a subsequent study, also a large multi-center study, 93 ICUs and 130,000 ICU admissions approximately, on what would be the effects of organization plus process. That being said, staffing patterns, the autonomy to perform interventions from the multidisciplinary point of view, and also how this would reflect on mortality rates and lengths of stay. And what this study showed was that, very interestingly, we could identify actually different clusters of intensive care units. So with a machine learning approach, what we showed here was that nurse autonomy to perform interventions such as sedation titration, vasopressor titration, weaning from mechanical ventilation, active mobilization, etc. That being said, to be able to implement actually in the bedside the evidence-based protocols that are recommended, was strongly associated with lower duration of ICU stay, lower duration of mechanical ventilation, but also lowest mortality rates. In this sense, not only having more nurses, but also having 24/7 intensivist coverage and a dedicated pharmacist, and the high autonomy from the multidisciplinary team composed actually what we consider the most efficient cluster. That being said, ICUs where you had the most efficient profiles. Also coming from a sub-study from the checklist trial that I recently showed, we evaluated what were the factors that could be associated with some of the ProcessOfCare measures and achievement of goals, such as sedation goals. And what we showed in this study was that there were some organizational factors and process factors that were associated with being on target regarding to sedation in the first 48 hours of mechanical ventilation. What we showed here is mostly that the presence of board certified intensivists, at least in the morning, but preferably throughout the whole day, was the main factor driving achievement of sedation goals. In a subsequent study from the same database, we tried to look with a similar approach and what factors would actually interfere with the improved adoption of protective mechanical ventilation in the ventilated patients. This is very important because we know that there's an important gap from the evidence to the implementation of these evidence-based recommendations. So what we've shown here in this study was that nurse staffing patterns, meaning the nurse to bed ratio, but also the presence of nurse intensivists, and also the use of checklists were associated with increased adoption of protective ventilation. Therefore, I think that we could be convinced that we have enough evidence that ProcessOfCare measures are strongly associated with ICU efficiency. So the next step would be, how can we measure it? So in the next few minutes, I'm going to go through this. So the first thing would be the routine use of checklists. So either using checklists that are available in the literature, the checklist from the checklist trial, the fast hug approach, or a locally tailored checklist that's implemented in different ways. So first, it could be implemented, and there's evidence that it works if implemented at least 5 times per week. You don't need even to start implementing and using it every day or twice a day. But if you use at least 5 times a week, 5 days a week, and preferably to the highest risk patients, meaning those that are expected to stay for more than 24 or 48 hours, that already is something useful. This would be what we call the routine use of checklists. And the measurement could be done in different ways. Could be done in paper, electronic assessment, but the more important is to get the information of the percentage of adherence to the recommended practices that are actually contained in the checklists. In a similar way, the percentage of adherence to care pathways and protocols to certain conditions and diseases or to preventive measures could be a relevant way to measure process of care. Finally, as we know that the efficiency of implementation of checklists and protocols are related to staffing patterns. Periodic assessment of the adequacy of staffing pattern to the complexity and profile of your intensive care unit should be measured and associated with the first items that I mentioned. So finally, why do we need the checklists? So we need checklists for several reasons. We know that we are not perfect, and the ICU environment is very complex with associated with very high cognitive load, and that we are prone to errors as humans that we are. So checklists, as I demonstrated before, could be used to improve the adherence to evidence-based measures. And finally, not only you should apply it in a daily basis or at least 5 times a week, either in an electronic form or paper, but the more important, measure and give feedback to the team from the results that you get to checklists, because the audit feedback could be a way to improve the adherence. The last part. So should we benchmark process of care? It's a little bit more controversial. There's not a lot of data in this area, but what we do know is that maybe we should measure it and benchmark as well. But some authors would say that we should just consider that the higher the better, and the benchmark would be 100% adherence to whatever the recommendation is. Um, However, if we choose to benchmark, why should we do it? I think that the first reason would be because benchmarking provides us targets for improvement. And using real world data, we could have a sense of where we want to be when we compare to better performing ICUs that have similar profile to our own ICUs. Finally, how can we do it? So we can do it looking into different databases, using data from the literature, preferably using near real-time availability of data, and getting together into audit feedback processes where you're going to measure but also give feedback to the team, and at the same time have the benchmark of what's the ideal and what's the goal. These are very related to the use of gamification strategies that are at this point, as far as I know, not implemented in the bedside, but that are being evaluated as helpful tools to improve the adherence to process of care measures in different settings, from surgical patients to acutely ill patients. Thanks a lot.